stain it with KOH to give you a rapid diagnosis. And this is the wrong way to put it. Don't break the surface, because this will cause the results not to be accurate. And let's share now some of the real cases, real life cases. This is a child where user, contact lens wearer, he presented with severe pain. He's taking no treatment. Infiltration, you should define how deep and how wide is the infiltration, how big is the epithelial defect, and if there is hypopyon or not. And notice the hypopyon is a very important clinical landmark. If it is straight line, if it is mobile, this is usually indicative of bacterial origin. And the impression here, because of a lot of the discharge and the rapid progression, this is probably a Pseudomonas, which is the most common organism doing this. Still, we will do scraping and we will start the antibiotics, and you can see the progression of the case from day 0 until day 25, and you see the progression and the improvement of the condition until it is only a faint opacity. But you have to make sure that you are giving the right treatment in the right dosing and following up the patient, and don't get disappointed. If you don't draw or photograph the patient, you don't know the patient is improving or not. But if you draw and photograph the patient, you will know that he's improving, even if it's small improvement. Once he's improving, you should keep on the proper treatment. Otherwise, if not improving, you will change the treatment. This is a 70 years old male patient with a history of trauma by stick for few months earlier, with total corneal abscess off treatment. Culture, we did him scraping, alpha hemolytic streptococci with the proper dosing and treatment. You can see the improvement, and the improvement, there is starting vascularization, decrease in the infiltration, decrease in the epithelial defect, and at the end, after 15 days, the patient looks much better. Another case, a child trauma by finger. We see a lot of these patients. You can see the shape of the infiltration, the hypopyon. He was in some other treatment. We did him, the culture was negative. Our impression, this was bacterial because of the pattern of the hypopyon. You can see the follow-up of the patient over a long period of time, but there is improvement. So we continue in this treatment. Case number 4, 40 years old male, agricultural habitant. This is the thing that we always think about, fungal infection. Again, we record the infiltration, the epithelial defect, and the hypopyon and how it looks. And the medication, he was giving several antibiotics, natamycin, combination for a month with no improvement. Once we changed to fluoroconazole, which is Vifan, with the proper dosing and following up the patient in 1 week, 2nd week, 3rd week, 4th week. You see, it's a long period. You have to tell the patient from the beginning. It will take time, even if you are in the right track. And you can see the improvement over 8 weeks, and even more, that it changed completely the clinical picture from a very severe infection of the cornea, infiltration of the cornea, to something that you can deal with later on. So if this fails, even if you are on the right track, if the treatment is not responsive, you have to think how to interfere. And this involves surgical management, either cross-linking, amniotic membrane, tissue adhesive, conjunctival flap, or keratoplasty. And I'm going to stress on 2 things. The cross-linking, you can see this is a patient, even with acanthamoeba. We use now cross-linking to help the treatment or to improve the condition in cases, even acanthamoeba, fungi, bacterial, and you can see the change of the patient. Another patient post-LASIK infection, which is a thing that you can see here. He took all the antibiotics, flap amputation, cross-linking. You can see after cross-linking how the improvement over time changed the condition completely into a very faint scar, and the patient can accept the results he gets. But there are other patients that really does not improve. And they start to go from one doctor to another. Everyone is changing the treatment. Everyone is telling them, we cannot do anything until you are cleared, your eye is quiet. And this is completely wrong message. If the patient is not improving, you have to do a hot keratoplasty. And this is a teacher that is 30 years, 2 years old patient that had 2 bilateral infection, and over the months there was heaping of the epithelium, thinning of the cornea, infiltration, and she was miserable vision, hand motion. So I decided to do a hot penetrating keratoplasty in one eye, and I had no choice but to put a fresh amniotic membrane in the other eye, because I can't do both. And here you can do it even freehand, and don't worry about bleeding. Just bleeding will stop. Don't cauterize, because this induces more vascularization. And you can see this is a bacteria. It was atypical mycobacteria. And typically of bacterial infection, there is not too much involvement in the anterior chamber or the posterior chamber. So you put the graft, and usually in these cases you use interrupted sutures, because you selectively will remove these sutures because they get loose in a differential manner. Where it heals, it gets loose. And the other eye, I just did an overlay, stromal side down overlay, fresh amniotic membrane, because I didn't have another option to do it. I did partial tarsorrhaphy, and then the patient started to, we follow up. You see the eye quietened, all the vascularization, because you remove the cause of the inflammation. Like an abscess you have, you open it. It's logic. If you wait, keep waiting, the eye is lost. You have to take a decision. So you can see after 4 weeks post-operative, the remnants of the amniotic membrane. After 1 month, you can see the graft is clear, the eye is quiet, anterior chamber well formed, and the other eye, there is still remnants of the amniotic membrane. As you can see, 1 year post-operative, much improvement. The patient can see 3 years post-operative, the graft after removal of the sutures is still clear. And amazingly, the other side for the amniotic membrane is the cornea is reconstructed. It became clear. Again, this is, you can see the edge where the heaping goes and the infiltration. This is not a graft. This is the eye of the amniotic membrane, and the patient can see almost as good as the other eye. And 5 years plus, now I see her for 13 years. The graft is good, the other eye is good. Now she's getting more posterior subcapsular cataract, and she's doing very, very well just by taking the right decision. This is another girl that was having her wedding in 2 weeks and 2 months, and she did PRK. She got infection in one eye. She was going around, but she came to me and she was giving treatment, and the doctors told her we cannot do anything except that after the eye quietens. But I was seeing that in spite of the proper dosing and treatment, there was no improvement. So a decision should be taken. And so I told her we will do a penetrating keratoplasty, hot keratoplasty. And in such cases, you will see the difference between a fungal infection and bacterial infection. You can see here, I'm doing this freehand as well. You should remove the area of infiltration as if you're draining an abscess, removing an abscess. This is the cause of the problem. The longer you wait, the more damage is happening, and the worse is the prognosis, even if you do keratoplasty later on. This is, remember, almost 2 weeks or 3 weeks post-infection. So you can see inside, this exudates inside the anterior chamber, and this exudates have the fungus inside. This is the difference between hypopyon in a fungal infection and bacterial infection. If you have a fungal infection, you can wash the anterior chamber from the hypopyon. If you have bacterial infection, this is actually you don't care to remove it. You can see the posterior synechia, and very commonly you will have clogs of bacteria, of fungi behind the iris even. So you have to clean this. You form the anterior chamber angle because you don't want to get secondary glaucoma. And then again, interrupted sutures. And this 1 week post-operative, the eye is much, much quieter. You removed the inciting factor. This is the most significant thing to understand. This is 6 months later, and then she got married, invited me to the wedding. She had a nice kid afterwards, and later on, 2 years or 3 years later, she came with the cataract. You can see there is posterior synechia. The graft is clear. So I told her we will do the cataract surgery, dissect the synechia, and then you do your cataract careful enough to protect the corneal endothelium of the graft. And also you can, because the pupil is atonic, so you can combine this with, after implantation, with pupilloplasty, that if it is small enough, like Ammar Agrawal, it will improve, it will help the uncorrected visual acuity by improving or overcoming some of the astigmatism that the patient will have in such cases. So it's a regular phaco case. And then we implant, and this is 5 years post-operative of following the hot keratoplasty, cataract extraction, and pupilloplasty. And she had another kid. So in conclusion, corneal infections can be a cause of blindness and morbidity. You have to have a plan to reach diagnosis. Use all tools available. Treat aggressively and in a timely manner. Take your decision in a timely manner. And you can save vision with your knowledge and experience. Thank you for your attention.